So I'm going to talk about the clinical science underlying optimal use and teaching of imaging in glaucoma. Initially, I developed this course, and one of the places I took it was during Anne's gig, and Guy de Mello labeled it as a testing talk. And in some ways, it is testing because I'm not going to discuss the theory or the machines or the printouts or anything else, and I am going to assume, which in this audience is assumable, a basic knowledge of the principles of diagnostic testing, but I'm going to concentrate during this testing talk on likelihood ratios and their use. That's the main thrust of this, how to use it. I will provide the explanations. The calculations will be absolutely minimal, and I will talk about the estimation of pretest probability. How do you say this probability of glaucoma here is 5% or 20% or 50%? And going to talk about a nomogram that you can use to arrive at a post-test probability, and that's skipped from the nomogram. You can then use the computers to do that and give you a couple of practical examples. So that's what I hope to do during the course of the next 40 plus minutes. The concept of a likelihood ratio is required to interpret and apply the current literature on imaging in glaucoma. In fact, it is required to interpret the current literature on any diagnostic technique. So you take this article here, the enhanced detection of open-angle glaucoma with an anatomically accurate OCT-derived neuroretinal parameter by Bal Chauhan and Claude Bourgoin and friends of mine, and all the results talk about is sensitivities, specificities, and likelihood ratios. So what we need to know is a likelihood ratios of 14 with what we currently use, nerve fiber layer. Is it clinically significantly different from 16 that you achieve with this new parameter, in which case you should use the new parameter, otherwise it doesn't really matter. And you consider another article here from Bob Weinreb's group about the agreement of detecting glaucoma progression with the GDX and other techniques, and they also talk only about sensitivity, specificity, and likelihood ratios, but they don't tell you how to apply it. It's assumed that you know how to apply it. So if you don't know how to apply it, then this article is useless. And if you're using the HRT, then this article by Bal Chauhan again talks about progression using the HRT, but they again report only likelihood ratios and presume that you know how to use it. If you come to angle closure in glaucoma, then again the articles report likelihood ratios, positive and negative. So the clinical use of imaging, like any other test really, involves applying sensitivity and specificity. It involves combining the signs to achieve a high sensitivity or specificity, but the best method currently is really the use of likelihood ratios. In fact, the best method, the ideal method would be to use what are called multi-level likelihood ratios, and I'll briefly touch about that. So it's time then to just define a likelihood ratio. All of you have trained in good Western universities and you should know all this, but just a definition for my own purposes, I keep tending to forget. There's the probability of a given test result in those with disease divided by the probability of the same test result in those without disease. That's a positive likelihood ratio, and the negative likelihood ratio we'll talk about some other time. And all of you know sensitivity and specificity, and you know the table, and you know the 2x2 table that helps derive it and understand it. It looks very complicated. All I'm saying here is that sensitivity is derived separately from specificity, and there are two different columns. Sensitivity and specificity sum to 1. So sensitivity, how do you remember it? I remember it as Sackett suggests. PID, or positive in disease. The mnemonic what he suggests is remember it as PID, or pelvic inflammatory disease. How many of the diseased are detected? PID. And the complement of that, which is important, is false negatives. If sensitivity is the complement of sensitivity is false negatives. Specificity is negative in health. And how many normals are declared normal, and The way to remember it is NIH, National Institutes of Health. Negative in health, that is specificity. And the complement of specificity is false positives. So now we come to the likelihood ratio. The likelihood ratio of a positive test is the true positivity rate divided by the false positivity rate. And that in jargon means sensitivity divided by 1 minus specificity. So sensitivity divided by 1 minus specificity. And there are several advantages to using the likelihood ratio, both positive and negative. You can take the pre-test odds of the disease, what you feel are the pre-test odds, you multiply it by the likelihood ratio and you get the post-test odds. Is that sort of okay? Can't really be, because we think in terms of probability. What we have is our pre-test probability and what we want is post-test probability. The calculations are not that easy. It's very easy to calculate and convert between odds and probabilities, but I won't torture you with that today. We'll just forget about it and we'll use a nomogram to do the calculations. And once you've just understood this, you can use an application or the computer to do it. There are many apps available to do this. So let's look at this patient to start with, and let's say the intraocular pressure and the visual field is normal. And you look at the optic disc and you look at this nerve fiber layer defect, then in your mind you have we don't usually put it down, but you have a feeling for what's the probability this is glaucoma. In your own mind, every clinician does this intuitively. We are just scared to put a probability on it. Just for illustration purposes, I'm going to say this is 60%. It's not 60%. It's far higher. But I'm going to say this is 60% purely to introduce the calculations. So how do you assess this pretest probability? How do you say, well, this is 50%, this is 70%, this is 80%, and how do you teach it to somebody without wasting 20 years on it and say, from experience, this is so much? Well, that we'll come to in a little bit. This particular patient on the GDX had this abnormality, this particular abnormality here. Now, using our data that we had in LV Prasad, we calculated the likelihood ratio of that as 44. So this particular abnormality has a likelihood ratio of 44. How do you do that? It is sensitivity divided by 1 minus specificity for that particular test result. And then we used a nomogram to come to the post-test probability. So this is Fagan's nomogram. This is now computerized and in apps. And it has a pre-test probability as one column. It's got a likelihood ratio as the second column. And if you line them up, you get the post-test probability. So what you have to do here is you line up your pre-test probability that you have estimated, and you line it up with the likelihood ratio of that particular patient's test result, and you will wind up with the post-test probability for that particular patient. So in this patient, our pre-test probability is 60%. That's what I have said. And our likelihood ratio here is 44. So you start with a pre-test probability of 60%. And in a patient like this, if you feel the pre-test probability is 60% and this is the test result, your post-test probability is 98%. You should be 98% sure that this is glaucoma in this patient. Now, this particular patient, you then do a sensitivity analysis. So in the sensitivity analysis, you ask, you say, how low could it be? How high could it be? So just as another example, I have put that down as 80%. So someone feels this is 80%. If it's 80%, then with the same likelihood ratio, your post-test probability is going to be 99%. Looking at that clinical picture, my feeling for that is 90+% already. With that disc appearance, with that nerve fiber layer defect, I'm saying I'm 98% sure already. So I'll be 99.9% sure of the diagnosis after this test result. You can never get to 100%. But this is how it works. If someone in the audience or someone in the group feels, well, this diagnosis, I think it's only 50%, you can calculate using 50%. If at that stage, you are then above your threshold for treatment, then that's what you do. If at that stage there's still any doubt, then there are other options that you put in place. So the interpretation of the likelihood ratio, more than 10 is a large increase. Obviously, 1 is no change in the likelihood of disease, and the negative likelihood ratios, less than 0.1 is a large decrease in the probability of disease. To be relatively immune to your pretest probabilities, sensitivities and specificities are subject to pretest probabilities. To be relatively immune, you can calculate the multi-level, you can calculate what are called multi-level likelihood ratios, not just at one standard cutoff point which that company or the paper gives you, saying sensitivity this, specificity that, but you calculate it at different sensible, clinically relevant cutoff points in both normals and glaucomas, and then you develop and use the likelihood ratio of the result that that individual patient has with the pretest probability of that individual patient to arrive at the post-test probability for that individual patient. That's the best way to use it, not just a standard sensitivity, specificity cutoff that has been mentioned or what the machine hands out to you or what the paper gives you. This is the best way of approaching it, I feel. Now, monitoring with imaging. Imaging, if it's to be useful, it should be able to predict functional loss. Otherwise, what's the point? It gives you some values unless there is a prediction that this patient will have functional loss -% of the time over the next 5 years. If it's going to affect the quality of life, we take action. If it's not going to affect the quality of life, then we leave it alone. So this article by Bal Chauhan, they give you the likelihood ratio of a positive finding, the likelihood ratio, the probability that this patient is going to progress is what we are after. And the likelihood ratio there is 3. So 3, you know, is a small increase in the probability of progression in this instance. So you start, let's say you feel the pretest probability of progression is 50%. You start with that, with a likelihood ratio of 3, you will be about 80% sure that this patient is going to progress. If your pretest probability of progression is 50%. If your pretest probability of progression is 25%, then with the same likelihood ratio, you are now about 50% sure that this patient is progressing. Still pretty good. 50%, 1 in 2. But at the usual lower rates of progression that we see in controlled glaucoma patients, usual rates of progression, let's say 2%, if you feel the probability of progression is 2%, then with this sort of likelihood ratio, even if the test is positive, you're only 5% sure that this patient is progressing. It is important to assess the pretest probability. Now, GDX is another machine that we use, and the GDX likelihood ratios are a little higher. They are about 12 as reported. So if you start with a pretest probability of 50%, with a likelihood ratio of 12, if this test is positive, you are now 95% sure that this patient is progressing. But if the pretest probability of progression is 25%, with the same likelihood ratio, you are about 80% sure that this patient is progressing. At lower rates of progression in a stable glaucoma patient, if you find this result, if your other clinical pictures suggest stability and you find this result, then with this likelihood ratio, you're about 20% sure that the patient is progressing, and you may not want to step up treatment or progress to surgery and things like that. So the individual likelihood ratio, to be useful, you have to estimate the pretest probability of disease or the pretest probability of progression. And this is best done with a multi-level likelihood ratio at different cutoff points, not just at a single sensitivity and specificity. And you apply the results in an individual patient to estimate the post-test probability of progression in that particular patient. It is not a general sensitivity specificity that you use. And these principles apply to all tests, not just glaucoma and not just to open-angle glaucoma, but to swept source ASOCT and swept source ASOCT also. Now, I left out suspects. Now, all of us latch on to the latest technology and you think that ASOCT detects suspects. Now, what are suspects? Suspects harbor angle closure and angle closure glaucoma. Suspects are those who harbor angle closure and angle closure glaucoma. So to be useful, any technology, however expensive, not only has to identify suspects, but they have to also differentiate closures and glaucomas from suspects. So think about it, the machine doesn't necessarily do that. You look at this article from Singapore on swept source ASOCT, and it's exciting stuff there. They have provided likelihood ratios, but like all the other articles, they don't tell you how to apply it. They don't apply it either because they assume that you know how to do all that. And in addition, they have provided other valuable additional information. They have provided additional information as shown over there. This is like a multi-level likelihood ratio, but they don't discuss it in any way. This is like a multi-level likelihood ratio to apply to individual patients. And this is the type of data that you need in order to use our diagnostic techniques to their best possible ability. Let's come back to this article by Ball and Claude, and they tell you the likelihood ratios for the new technique and for nerve fiber, for the new technique, new parameter, and for the nerve fiber layer. They provide likelihood ratios and they provide other useful information. They calculate the post-test probabilities at fixed pre-test probabilities of 1% and 10%. So they calculate and tell you the post-test probabilities. But not all our patients are 1% or 10%. They can be different. And we have to estimate that and then use it. We should be able to estimate it for our own patients. The question is, how do you assess this blessed pre-test probability? We do it intuitively, and as you get more experienced, you use your own clinical experience, you use the history and examination, and intuitively looking at a thing, you can say, well, it's approximately so much. That's fine. But how do you teach a second-year registrar, a third-year registrar, and try to get them to within 5 to 10% of yourself without spending 20 years? How do you transmit that 20 years or 30 years? I'm sort of revealing how old I am of experience, and try to communicate and teach the skill. You can actually get to within 5 to 10% of colleagues with a little bit of training. So let's start with this 55-year-old male who's come in for a routine examination, no family history, and the details are shown over there. The pressures are 20 and 21. So in this case, and the angles are open, the angles must always be checked. What's the probability of glaucoma? You know only this information. He has come and sat down in front of you in the clinic, and this is all that you know. What is the probability of glaucoma? Now, if you know nothing else about this patient, the prevalence or pretest probability of glaucoma or any other disease that you might be interested in, a good starting point is the prevalence of that disease in the general population for that age group, for that ethnicity, and as close to that ethnicity as possible. Now, the fact that the patient has come to your clinic means it could be a little different, but this is a good starting point. And when I was trying to develop this course and develop this talk, I looked around the literature, and the only place I found good data was the GP literature. And this is the GP publication from the general practitioners. And this provides a lot of information that we can use to develop pre-test probabilities. And this is one of the tables from that article. So for a 50 to 59-year-old, the prevalence of glaucoma is approximately 2%. Approximately 2%. So that's a good starting point. And then you examine your patient. So you look at the optic disc. So you start with 2% and you see a disc like this. What does your probability come to? Does it remain 2%? You're busy eating, I guess, you should eat, you shouldn't talk. No, that's fine. Is it less than we thought? With that disc appearance, can we rule it out? And if you are lowering that probability, you follow Cooper's dictum. If the test is not going to change anything, you don't do it. So clinically, you started with 2%, you look at that disc and you say, no, not 2%, less than that. And obviously, clinical training is important. This is not a cookbook approach, because if the disc looked like this, it is still a large dysplastic disc and your probability is not going to change. So your clinical skills are important. If the disc look like this, your diagnosis changes, right? Your probability of glaucoma goes way down and your diagnosis changes. And if you look at a disc like this, again, it's a different diagnosis entirely. By the way, this patient was being treated for glaucoma. So, wrong diagnosis. But your diagnosis changes. Still, nevertheless, and if the disc looks like this, then your clinical skills tell you that this probability of glaucoma has gone up tremendously, and I'll go into how much more it has gone up. So let's start with this disc. Let's say the disc looked like this, and we keep it simple. I like to use rim to disc ratios and the disc damage likelihood scale, but we'll just stick to cup disc ratios. That's what this article sticks to. So the examples are like that. So a cup disc ratio of 0.4. And that article gives you the likelihood ratio of various cup disc ratios, and the likelihood ratio of a cup to disc ratio of more than 0.4 is about 2. So you start with the pretest probability of 2%. Your likelihood ratio is 2. You join up the lines there, line it up, and after looking at the disc for this patient, your pretest probability is about 5% for this patient. The article also gives you other data. It tells you about cup disc asymmetry, and you can use it in a similar manner. They also give you the diagnostic accuracy, the likelihood ratios of different cutoff levels of intraocular pressure. The article gives you that too. So another 50-year-old male myope, -6 diopters, no family history of glaucoma, 27 millimeters of mercury, angles are open. What's the pretest probability? What should we start with? If this chap sits down in front of you and this is the information you have, you look at the table there, -6 diopter myope, the probability of glaucoma is about 11%. That's what the studies suggest. Now, I'm making it relatively simple. This is not what we are after. The actual information we are after is a 50-year-old male patient given that he is 11 diopter myope. That's a different probability. But since I don't have that, we'll just use the higher probability of a myopia of more than 6 diopters, that is 11%. And a pressure of more than 25 has a likelihood ratio of about 8. So you start with the pretest probability of 11%, your likelihood ratio is 8. By the time you take the pressure, you should be about 50% sure this patient has glaucoma. That is how you develop the post-test probabilities. Before you do any further testing on him, this is what your pretest probability is. Another patient, a 55-year-old, monitored for a family history of glaucoma in the father and the brother. He is now referred as intraocular pressure high on 2 occasions, 23 and 24. Previously, they were within the statistically normal range. So what's the pretest probability in this patient? Now, intuitively, we know it's higher. How much higher? And you look up the table over there. With a family history, the prevalence is about 7%. Now, this is not exactly the information that I want. What I really want is a 55-year-old patient who has, given that he has a family history in both the father and the sibling. That is what I'm actually after. In the absence of that information, I will use this particular probability of 7.7%. So a pressure of more than 23 equal or that, it's got a likelihood ratio of 10. We have started with a pretest probability of about 11%. Your likelihood ratio here is 8. You're about 50% sure that this patient has glaucoma before you've looked at his disc, before you've done any tests. That's how the thing works. And if you were to find if his disc looked like this, then the pretest probability changes. How does it change? And that's the next bit that you're going to talk about. A 70-year-old male referred as glaucoma. He has had cataract surgery. He's got good vision. And his pressure is 18 now, on treatment. He is on treatment. Now, being on treatment doesn't necessarily mean he has glaucoma, right? Or being off treatment doesn't necessarily mean you don't have glaucoma. So this is the history for this particular patient. What's the pretest probability? So you look at a 70-year-old patient and the probability is 5%. This is not the information I'm after. The actual information I want is a 70-year-old patient, given that he has had cataract phacoemulsification, uncomplicated in both eyes, building in his ethnicity. We don't have that, so we'll use the 70-year-old and the prevalence as 5%. This is his disc. Now, looking at that disc, I think all of us will agree that the probability increases. How much? We are all not trained to put a number on it. There's a thought block there. We say, yeah, this is glaucoma. How much? So, we search the literature, and there is data there on a disc notch. And from the Blue Mountain study, they have provided the sensitivity and the specificity of a notch. What's the sensitivity and specificity of a notch? How do we use it for our patient? The sensitivity is 90, the specificity is 97. Predictive values have been provided, they have calculated and provided it, but that's not what we need. That depends on the prevalence, and so what's it for your patient? We need to calculate it for our patient. We can use the nomogram, but first we need to calculate the likelihood ratio of an optic disc notch. So, the likelihood ratio, just to remind you, sensitivity divided by 1 minus sensitivity. So, sensitivity divided by the false positivity rate. True positivity rate is 90% sensitivity. The false positive rate is the complement of the specificity. So, the complement 100 minus 96.8, and your likelihood ratio then is 90 by 3.2. 28 is your likelihood ratio. 28 is a very high likelihood ratio. So, you start with the pretest probability of 5%. Your likelihood ratio is 28, and at this stage you are about 60% sure that this patient is glaucoma. Now, intuitively we know it's much higher, and why is that? Because I did not take into account the intraocular pressure, is already on treatment, etc., etc. So that's how it works. So this pretest probability of 60% becomes your pretest probability for this patient before you apply any diagnostic tests. And then the diagnostic test takes it up or down. And you do a series of diagnostic tests, you just do it one after the other. And you can calculate one after the other. And you use the test results in the same way. So let us say for this patient, I brought up the same slide, that he has the same test abnormality with a likelihood ratio of 44. So at the end of your disc examination, you were 60% sure. You then do the GDX or whatever the imaging technique you have done. And in this case, the likelihood ratio is 44. At this stage, you are 98% sure that this patient has glaucoma. You can never be 100% sure. 99.9, yes. And that should be that, except when I looked at his conioscopy, he actually had angle closure, and this whole thing was preventable if it had been picked up early and an iridotomy done early. This whole thing was preventable. All right. This lady, 46-year-old, over the last 2 years, the pressures have been 15 and 17, referred for suspicious disc, and she says, I think my mother has glaucoma. She is progressing on OCT. What's the probability she's actually progressing? So you've got a patient like this, OCT is saying progression. What's the probability she's progressing? So these are her discs over there. 2009, 2011, those are the discs. What's the probability she's progressing? Now, if you look at Anders Hale's article from Sweden, probability of a patient like this is about 10%. I accept that that is Sweden, and I accept that this is Australia, but she is Caucasian. Chimpanzees are only 1% genes removed from us, so I think you can use similar data and say approximately so much, but you'll find reviewers and critics say no, wrong population. I don't have that data, so we are going to use 10% in this situation. What about the OCT abnormality? So you look up the literature and you find various sensitivity specificities. Hopefully this should be available for this patient. I'm just going to say that, let's say this applies to our patient just as an example. Sensitivity is 85%. 100 minus specificity, that's your 100 minus specificity is 13%. So your likelihood ratio you calculate as 6 or 6.5. So you started with a 10% and your likelihood ratio is about 6. When you see the OCT result, you're about 40% sure. Then it becomes clinical. Is she young? Long life? 40% is good enough to step up treatment. If she's older, 2 heart transplants, 1 kidney transplant, maybe you don't want to do anything about it. Just as an example, this is a different article and this is a different sensitivity and specificity, but I'm going to apply it to the same patient just as an example. Sensitivity is 77%. So the false positivity rate is what you need. So 1 minus specificity. You can work this in your head. You really don't need a calculator, right? 20. So at 20, 80 by 20, about 4, 3.85 comes to about the same thing. You can calculate the likelihood ratio. You start with a pretest probability of 10. Your likelihood ratio is there. And you are approximately 25% sure of the diagnosis. So at this stage, you don't know, am I going to watch? Am I going to step up treatment? If you were 50, 60, 70% sure, you would probably step up treatment. And most of us have a threshold where we say, I have to step up treatment in this patient. Now you look at this patient's disc, the other disc over the last 2 years. And you can see how the rim there is lost. You can see the nerve fiber layer defect here has increased. And this is before we've done the OCT. So in this particular patient, what is your clinical pretest probability? Is it 10%? Right? And in this particular patient, do you really need imaging to confirm anything in this patient? Just the other side of it, that imaging is very useful and things, but if you're doing a good clinical examination, you can pick up a lot of it. If you're not doing it on a regular basis and you use it carefully, then yes, imaging is very useful. And in this case, at the same time that imaging picked it up, she also had a visual field change. So in the last 32 minutes and 44 seconds, we spoke about likelihood ratios and their use. I provided some explanations. I avoided the calculations because most ophthalmologists like myself are numerophobic and we don't like calculations. We spoke about how to estimate pretest probability and we can take this forward. It's a good project for someone to test out, how does this work? How close can you get to each other? I explained the use of the nomogram for post-test probability and provided a couple of practical examples. But you don't really need the nomogram. There are online calculators and you can go up online and plug in one test after the other, the likelihood ratios, to arrive at your post-test probability. And this can be built into diagnostic machines. So you can, for your patient's test result, the likelihood ratio can be calculated. What you as a clinician have to do is plug in your pretest probability and you arrive at a post-test probability. You can then decide that I feel the probability is different. What's the lowest you feel it is? And if you're still above the threshold, you're on a good wicket. You still have to estimate pretest probability. You still need the clinical skills to say, well, this diagnosis is not glaucoma, it's something else. But this is the way to go. And when I speak to some of my colleagues in industry, they said, but Ravi, you're asking ophthalmologists to estimate pretest probability. That's impossible. It's not impossible, right? With a little bit of work, I think we can do it. And I think, again, I repeat, this is a good project for someone to do that. How does it work in real life? How close do you come to each other? So imaging is very useful, but what's important is how you use it. And what I've explained to you is just the clinical science behind using such sophisticated tests. But this science is applicable to every test, starting with hemoglobin. The principle for all diagnostic instruments, however expensive they may be, and however seductive the printout may be, the principle for all diagnostic tests is the same. The machine has no brain. You're expected to use your own.